today. Dr. Pack got his Bachelor's of Science at University of Alabama at Birmingham in psychology. Also at University of Alabama, got his Master's of Public Health and Health Behavior, got his Ph.D. in Health Education and Health Promotion, and his postdoctoral fellowship at Emory University, Rollins School of Public Health in STD and HIV prevention. Dr. Pack is currently a professor of community and behavioral health, associate dean for academic affairs in the College of Public Health at ETSU, and director of the new ETSU Center for Prescription Drug Abuse Prevention and Treatment. Dr. Pack also worked at West Virginia University as an assistant professor for a number of years before coming here. And I'll leave it up to Dr. Pack now.
Yeah, thanks. Good morning. It's great to be here. I appreciate the invitation of giving grand rounds in psychiatry. I think this is my third time. And I've always enjoyed coming over and the interaction. Hopefully, I won't just be lecturing you today. Hopefully, we can have some true interaction. And we can learn from each other. I'm going to talk to you today about prescription drug abuse and a little bit about epidemiology, about stigma related to mental illness and substance abuse and treatment of go ahead and move forward. I have nothing to disclose, no conflicts of interest related to this topic. Okay, so just a little bit about the epidemiology of the problem of, well, the number of people that have a substance use disorder, and then we'll kind of move into sort of the epidemiology of the problem in Tennessee and a little bit about lessons learned here. So this is data from the NSDA, National Survey on Drug Use and Health. And it basically demonstrates that there's about 21 million people with substance use disorder in the past year. And this is how they break out. With alcohol use disorder on top, illicit drug use, and then marijuana, and then pain reliever use disorder, and so on. Of those with alcohol use disorder or illicit drug use disorder, you can see the overlap in the middle. There are about 2.6 million people with both alcohol and illicit drug use disorders. And then substance use disorder and mental illness, there's about 8 million people. Okay? So about 36 million in total with mental illness and 20.2 million with substance use disorder, about 8 million in the middle. So related to pain relievers and opioid pain relievers, or OPRs, we'll talk about them, I guess, in that, or opiates or opioids. The U.S. has far and away the greatest consumption of opiates. And Tennessee actually is the second greatest consumer of opiates, and right after Alabama by 1/10 of a percentage point. And in East Tennessee, we have far and away the greatest consumption in the state. So we're the highest using, we use the most in the second leading state for opiates. And so there's a whole lot of pain relievers on the street and that folks are using. In fact, we believe that in the state, there's about 5% of the chart, which is a little misleading because that bottom section of the pyramid is broken into thirds, but it's clearly, 95% in the bottom third, so it's just not accurate. But we believe that this around 5% is what we're dealing with respect to early intervention or needs treatment. Okay, that's a lot of folks in our state. And there are a lot of negative outcomes that come from this. We all have heard a lot recently about the overdose problem, but let's take a few minutes and kind of work through this overdose problem, because it was happening for a long time and we weren't paying attention. Okay, this is actually 1999, and these are all the counties in the country. And red is the worst. Red is actually more than 20 per 100,000 in terms of overdose deaths. And blue, really purple and blue is really 0 to 4 per 100,000. So that's sort of the gradient. And the National Center for Health Statistics put this map together. So this is 99. And what I'm going to do is I'm going to take each of the years and lay them over on top. Okay, so when I click forward, it'll animate and it'll go 99, 2000, 2001, and so on. Just kind of keep laying them on top. Okay, so watch for red. Okay, so this is 2000, 2001, 2, 3, 4, 5, 7, 8, 9, 10, 11, 12. And there's 2014. So we went from this. Most counties in the nation with 0 to 4 or 5 overdose deaths per 100,000 to basically this situation in 15 years. That's amazing. I mean, it's staggering, really. And how do we get here? There's a lot of potential drivers, but I want you to look at one particular slide. In 2002, there was actually only one place in the country that had counties, contiguous counties, more than one county touching each other, that actually had an overdose death rate of greater than 20 per 100,000. It was in Central Appalachia. These other counties out in the west, that's actually a giant county over there in New Mexico. It's massive. It's one county. But in Central Appalachia, we actually had 23 counties touching each other. 23 contiguous counties with overdose death rate of greater than 20 per 100,000. And no alarms were sounded. Nothing was really done at that time. And there were a couple of people that were beginning to notice, but that points to us being asleep at the switch. This is crazy, especially given the situation that we're in now. Where we happen to live in Northeast Tennessee, Southwest Virginia, this is our situation. Of the rural and what are called rural and frontier counties by the USDA, in Tennessee and Southwest Virginia, there are 26 such counties. All of them have statistically significantly higher overdose death rates than both the state averages and, of course, the national average. Some of them are in the 40s, and there are actually overdose death rates for the age group 18 to 44. In some counties in Southwest Virginia, they're in the 70s, 70 per 100,000. Unbelievable. And here we are. At this point, there's a massive amount of heroin that's moving into the market because we're basically beginning to cut down on the amount of supply of OPRs coming from pharmacies. And the heroin is being cut with fentanyl and carfentanyl. We've all heard of this recently. There were actually 27 overdoses on this particular day. These 26 that were reported, all those folks lived, which is a good thing. And about, I think, 10 or 11 of them were revived with with naloxone, and the rest were bagged, and they were with breathing bags. There was one death, I think, from this particular outbreak. The following weekend, there were over 100 overdoses in Cincinnati. That's where we are at this point. We also are vulnerable in this region to an outbreak of HIV or hepatitis C like we saw last year in Scott County, Indiana, where they had about 200 cases of HIV in a county where they thought they would have 5 that year. This is all secondary to needle exchange, and basically is becoming an epidemic in that particular place. Now, some folks at the CDC began to model where this might happen next, and these are the 220 counties in the nation where they believe that same type of outbreak could happen next. This is a popular media piece from the Wall Street Journal that took the map and published it, but the peer-reviewed article about this just came out about 2 months ago. We know that heroin's increasing dramatically among most demographic groups, and in Tennessee that's also true. And overdose deaths are climbing dramatically. And we also know that we have a tremendous problem with neonatal abstinence syndrome. Babies being born dependent on narcotics. And this is our situation in Tennessee, with Northeast Tennessee being the area that has the most babies born dependent on narcotics. Now, most of them are actually the source of the narcotics is known, and it's typically can be buprenorphine products, and it can also be painkillers that they should be the moms should be screened for, but they're not necessarily. So this is our situation in Northeast Tennessee, far and away the greatest burden in the state. And there's all kinds of reasons why this is a bad thing, not the least of which is, they're very, very expensive babies to treat. And we are not sure exactly what the long-term implications of this are for the children. There's a neonatal abstinence syndrome working group on campus. Is anybody part of that? Okay, great, fantastic. It meets every other Thursday, and Dr. Wood, Chair of Pediatrics, is the co-chair of that. I think Beth Bailey is also co-chair of that. So if you're interested in that topic, I encourage you to get involved there. So we use this slide to talk about sort of the complexity of the problem. And it's because it's almost as if, everybody sees it from their own perspective, and the solutions aren't only from one perspective, right? So we actually know that there are a lot of drivers to this problem, and there are a lot of potential solutions. And so we use this as a model. This is basically the continuum of substance abuse, from non-use to death, if you will, with unchecked use. And then this is sort of the danger zone, this red oval. And then the purple and the orange are really dependence and addiction, transitioning from dependence to addiction. And this is first initiation on into greater use. And so what we know is that any given part of the continuum can be influenced by different evidence-based interventions. Okay, we know, for example, that there are excellent evidence-based primary prevention interventions. There's over 300 of these. You can access them at the National Registry of Evidence-Based Programs and Practices, or NREP, NREPP, from SAMHSA. It's a fantastic site, and if you're interested in a good primary prevention intervention, go there and then put in your criteria that you're interested in, and you can find a number of different interventions that you can access, and actually it'll give you really excellent information in lay terms about the effectiveness, cost effectiveness, and so on. We know that there are excellent interventions on that side We also know that diversion control programs can work. We saw a dramatic decrease in doctor shopping in the state. For example, about a 36% decrease in doctor shopping whenever we mandated the use of the PDMP in Tennessee. That's an excellent intervention, policy-level intervention. We know that traditional and medication-assisted treatment can be very effective when done well. I'll get into the details about some MAT here in a few minutes. We know what their effectiveness is, and even cost effectiveness. We know that naloxone works. I have to say, though, that from a public health perspective, if we're focusing on naloxone, it feels like we've missed the point. And I've actually often said that it feels like a failure of public health to be focusing on naloxone. But we have to do it because it is effective. We know the drug courts are really good. In fact, they're quite good at getting people back into the situation where they can begin to achieve some health. We know that this problem of neonatal abstinence syndrome is a tremendous one, and we have to focus on getting people, getting moms who have delivered a baby with NAS, getting her perhaps connected to voluntary reversible long-acting contraception. And we know that ESPERT is promising. I think the Department of Psychiatry had an ESPERT grant for a number of years, right? Is that right? I think so. And ESPERT is very promising, and we know that that there are finally some good tools for health professions training and continuing education. We know so much about these things that there's even really good cost effectiveness data at this point. Cost effectiveness for primary prevention, or I guess return on investment, is very, very high. We saw a tremendous decrease in doctor shopping. We know what the ROI is, for example, for MAT. This one's interesting. Naloxone actually is sort of inverted when it comes to return on investment. 227 kits dispensed for one save. Now that was prior to the spike that we've seen recently in overdoses. So this is a little bit older, maybe 2 or 3 years older data. So, but nonetheless, one save for 227 kits. We know what the ROI is for drug courts and for Verlac, as well as for ESPERT, and so on. So we're actually only inverted really in one place in terms of return on investment. Unfortunately, it's a place where we're spending a lot of time and resources at this point, but we have to do that for naloxone. These are some of the clinical guidance tools and educational tools for different groups. This year, the CDC came out with the prescribing guidelines for OPRs. That was great. As well as this is the ASAM National Practice Guideline. It was recently updated. There's also the ASTO. This is Association of State and Territorial Health Officers, and the one in the back is for clinical pharmacy or community pharmacy. So what have we learned so far? The problem we've discovered is bigger than we anticipated. There are supply side drivers to the problem. There's a lot of money being made in OPRs, a lot. The efforts to address the problem have been fragmented historically. Policy is absolutely key, but unfortunately policy isn't necessarily done where it's influenced by data, or sometimes policy is actually put forward that is done in the face of data or in spite of data. So, but it's absolutely key, and states need to be doing this better, actually. Politicians, we've learned, are concerned about the workforce, and if you want to get a politician engaged in this activity or in this on this problem, talk to them. Talk to them about the workforce and keeping the workforce healthy. Another thing that we've learned is if you engage with the community, if you show up, the community will respond well, and that has really paid off for us. There's a lot of tension in the recovery community. pretty staggering amount of tension actually between sort of MAT and the MAT group and the abstinence-based group. And this concept of stigma keeps coming up. Okay, so let's talk about stigma and some drivers of stigma. So this is just it's kind of like a social ecological chart that demonstrates some of the socio-cultural factors that impact substance abuse and different tools to address it. But basically, it just points to the complexity of what's going on from both the individual level all the way out to the community level. This is probably the most challenging chart to get through, and I'm not going to take you all the way through, but it points to this same level of complexity, right? All of the different drivers that are happening from the social, psychological context to the disease, all the way out to the community, but with stigma being central to how it's sort of how it is generated, as well as sustained in terms of our the problem in the community. But this is a lot simpler. We'll focus here for a couple of minutes. Stigma is actually broken out into a couple of different levels. And so not only do you have public stigma, but you have self-stigma, structural stigma, and then stigma by association. This is all, there's a whole field of study in each of these different areas. It turns out that there's quite good work being done in this area. But with respect to substance abuse, we really have enormous public stigma. There's a belief that individuals with mental illness, especially drug dependence disorder, are a danger. We saw this a lot when we began talking about putting a clinic in Gray. A lot of folks were very concerned that we might, they might have people kind of going through the garages and taking their lawnmowers and so on. It could happen, but it hasn't historically happened in other places where there are well-run opioid outpatient treatment programs. There's beliefs about shame, blame, incompetence, punishment, and criminality. And stigmatizing actions often come in the form of social distance from individuals with mental illness, especially drug use disorders. And this is actually clearly evidenced in this next study, which basically shows that so this is the x-axis is the bars are mental illness and drug addiction, and this is percent of people who say that they would like to have this happen. Okay, would you like to have somebody marry into your family with a mental illness versus substance use disorder? Okay, so mental illness, much more likely than substance use disorder. How about work closely with someone on the job, or discussing maybe a serious problem with them? So this is just it's just some more evidence about stigma. Would you be willing to deny employment, for example? Yes, much more likely for folks with an addiction over mental illness. And you can see the rest of those. So it's just kind of the difference between mental illness-related stigma and substance abuse. These are people with substance abuse and mental illness actually report higher anticipated stigma, so they themselves think about what people might be feeling, how people might be feeling about them. And in a couple of slides, I'll show you some more data and where some of the sources of that stigma when it does happen. Actually, I'll go ahead and do that now, and then we'll go back to that one. So this is actually stigma sources from the form of prejudice, stereotypes, and discrimination, mostly coming from family and friends of the person with the opioid or other use disorder. These are patients receiving methadone treatment in this study. This is a qualitative study, and this is where their stigma comes from. And often that can even be from the healthcare workers. So stigma among community members, drug treatment, and other professionals exists. It's pretty tremendous, actually, in terms of this tension between the MAT and the abstinence-oriented treatment community. And folks generally feel like compulsive drug use is a choice. It's a moral failing, and methadone, for example, is a crutch. It just replaces one drug addiction for another, and that it prolongs addiction and prevents full recovery. And that people should be encouraged to end treatment quickly, taper quickly. Now, that is also a very prominent belief in this area. I have to say that my instinct on this is also one of, if we can encourage people to get fully away from methadone, that would be the best situation. The data does not necessarily play out that way. We actually see that folks tend to do better with longer periods on methadone, and this counter to maybe our instincts and what we would hope for. So, what does the data say about buprenorphine and methadone treatment? Well, so if you consider randomized control trials to be good, and then you consider systematic reviews of randomized control trials and/or Cochrane reviews to be, sort of the pinnacle of evidence. This is actually, the next two slides I'm going to show you are actually the step above those, which is reviews of reviews. So reviews of excellent reviews, okay? So this is actually a review of reviews from 2014, and basically shows that methadone maintenance therapy has a positive impact. At the end of the day, we can say it has a positive impact on retention and treatment, where they're going to gain some access to counseling, gain some access to things that are going to help them get control back of their lives, as well as has a positive impact on illicit opioid use. We sort of look at it like when you can get people engaged in MAT in some way, every interaction at the OTP will be an interaction, an illegal interaction that's averted outside, because you're, in essence, you're changing the type of environment where they have to find the substances that's going to ease their physiological cravings. So the evidence is less clear but suggestive that MMT has a positive impact on mortality, illicit drug use, drug-related HIV risk behaviors, and criminal activity. And it suggests it has little impact on sex-related HIV risk behaviors. This is buprenorphine therapy, and so the evidence clearly shows that BMT has a positive impact compared with placebo on retention and treatment and illicit opioid use. And it's mixed for its impact on non-opioid illicit drug use. So related to stigma, again, this basically is in the right-hand corner a diagram of sort of the role that it plays. We have our culture that sort of feeds into stigma, the network and the knowledge, and it can influence in a negative way or positive way care seeking and participation. These are basically, on the left, are reasons for not receiving mental health services in the past year, and stigma is prominent there. Third behind costs and low perceived need. And so the broad impacts of stigma are here. So it directly affects the persons with mental illness and their support system, and their network and their community resources. Has adverse impacts on pretty much all the domains in their lives. People deny housing, for example, all kinds of negative impacts. And it's linked to poor mental and physical health. And it's argued to be a fundamental cause of population health inequities and maybe a central driver of morbidity and premature mortality. So this is just another model related to sort of how stigma works in terms of structural, interpersonal, and intrapersonal stigma. So there's evidence for effective interventions across different levels of the ecological framework, and there are some promising approaches that are between these different levels. So some examples of these anti-stigma strategies for self-stigma, for example, are therapeutic interventions, group-based acceptance and commitment therapy, for example, peer support for folks that are dealing with self-stigma. For public stigma, education programs, there's some pretty good evidence for those. And communicating positive stories of recovery, you'll see more and more you'll see us doing that more and more in this area as we begin to open the clinic and move forward there. Increasing contact with persons with mental illness, and so that you can kind of destigmatize their situation. And motivational interviewing can work well there. And then with respect to structural stigma, just dealing with some policies that are more welcoming for things like clinics, as well as contact-based training and education programs for med students and other professionals. Now this is very important. I don't know if med students are necessarily socialized in an environment where substance use treatment is discussed a lot and talked about, in a way that's on par with other conditions. So we need to be promoting culture of competence to address stigma, and this is a SAMHSA TIP, which is a treatment improvement protocol, and you can gain access there. But these are some of the basic content out of that text. So I'll tell you a little bit now about our working group and sort of what we're doing with the group as well as with the clinic. We've had a working group going on for about 4 years. There's about 150 people on the email list. Is anybody in the room on the email list for the prescription drug abuse misuse working group? So 2, 3? Okay. If you're interested, send me an email. I'm at pacr@etsu.edu, and real easy to find. If you're interested, we'll just put you on the email list, and then we'll send you an invitation so you can get it in your calendar. We meet on the second Tuesdays from 4 to 5:30 of every month. Sometimes we have more people there than other times, but usually we run about 20 to 40 folks each month, and it's a highly interprofessional group. We're beginning to do this thing where when we meet on campus, we discuss more like RFPs or more science-based, more research-based topics, and then every other month we meet off campus too, and we're using those meetings as more of a networking style meeting where we try to connect folks with different projects that are going on in the community. It's highly interprofessional, and we do focus on research as well as community outreach, education, and trying to really focus on systems level thinking. That's our goal. This is a slide that is kind of how I think, I guess. But so sort of the working group is a fertile ground for a lot of project ideas. And green is good, red's bad. Orange is just what's bubbling up next and going forward, I guess. And different like blue, for example, that's a proposal. Well, at least when I made this slide, that one's under review. We've had a number of different projects that have either been funded or that are active from the working group, including a large NIDA grant. When we've been doing a lot of research from that, we have 3 different projects within that grant alone, as well as an NAS grant and one on stimulant misuse, and working with the local government to do better drug-free workplace policies